Some form of orofacial pain is one of the main reasons why people visit the dentist. When we say orofacial pain, there is a spectrum of various conditions that can cause that. Burning mouth syndrome is one such pain condition that is poorly understood and most probably neuropathic. What does it mean? It means pain caused by a lesion or disease of the somatosensory nervous system. International Association for the Study of Pain defines burning mouth syndrome as burning pain in the tongue or other oral mucous membrane associated with normal signs and laboratory findings lasting at least 4 to 6 months. An important thing about burning mouth syndrome is that there is a burning mucosal pain with no significant physical signs, which is why it is very difficult to diagnose it, and it is common in women after menopause. Another important characteristic is resistance to a wide range of treatments, which is why it is one of the most challenging conditions to treat. The diagnosis itself takes a lot of time. Between onset and diagnosis, there is an average delay of about 13 to 41 months. You can imagine the patient's frustration. This syndrome has a lot of names like stomatopyrosis, glossopyrosis, stomatodynia, glossodynia, sore mouth, sore tongue, and oral dysesthesia. It can be classified as primary and secondary. The clinician has to examine the patient for local, systemic, and psychological factors as shown here. These conditions could be associated with burning mouth syndrome. So, a complete blood test has to be carried out with tests for iron, ferritin, vitamin B12, vitamin D, blood sugar, thyroid, and parathyroid hormone. This will help us diagnose the systemic conditions the patient might have. If one or more of these factors are present in a BMS patient, the condition is considered to be secondary BMS. And if all of these contributing factors are at normal level, then it is called as primary BMS or idiopathic BMS. The word idiopathic means without a cause. The second classification system depends on the onset of symptoms. In type 1, the pain increases during daytime. In type 2, it remains constant throughout the day. And in type 3, the pain appears intermittently with pain-free periods. Now let's talk about the causes of burning mouth syndrome. The etiology is really complex and multifactorial. Recent data has shown that the reason for BMS could be a purely focal small fiber neuropathy in the tongue and other oral mucosa. This neuropathy is thought to affect salivary secretion and oral sensation. Other findings suggest that the cause could be peripheral neuropathic conditions of the trigeminal nerve, taste nerves, and the cauda tympani nerve. Think of the trigeminal nerve and cauda tympani nerve as good friends that provide a service to the oral mucosa of the tongue. The service is to provide innervation. If there is damage to either of these nerves, it can adversely influence the other. For example, a common consequence of ear infection is damage to the cauda tympani nerve. Even though this friend is down, the other continues the service of innervation, so this can lead to trigeminal innervation of taste buds, but that results in altered taste sensation and pain. So this is one proposed mechanism. Histologic studies have shown an overexpression of certain receptors for pain, like TRPV1, that is transient receptor potential vanilloid 1. These TRP ion channels have an important role in temperature perception, sensitization, and nociception, that is, detection of painful stimuli. And if there is an increase in the number of TRPV1 receptors, it could result in heightened pain sensation. So, this is one school of thought. Remember this receptor when thinking of burning mouth syndrome because some of the treatments are also related to this receptor. Then other investigators found significant alterations of gray matter volume in the pain-related area. So it is proposed that central sensitization is one of the many factors that play a role in burning mouth syndrome. Central sensitization means the patient has hypersensitivity to stimuli from things that are not typically painful. This suggests that there could be a central deficiency of pain control in these patients. Endocrinological etiologies have also been proposed. As you know, this syndrome is more common in women after menopause. Why? Because after menopause, there is a reduced synthesis of ovarian steroids, which can result in a dysfunction in adrenal steroids. And adrenal steroids have neuroprotective effects on neural tissues. But because of this dysfunction, they lose this effect. So, this could be a reason why it's common after menopause. Local etiologies should also be considered as causative factors. These include candidiasis, poorly fitting dentures, parafunctional habits, oral mucosal diseases like benign migratory glossitis, and local allergic reactions. Other systemic factors such as nutritional deficiencies, anemia, diabetes, and xerostomia are possible causative factors. The pain associated with burning mouth syndrome is usually thought to be of psychogenic condition. There is a distinct correlation of anxiety and depression in these patients. When these factors are involved, it is called as secondary BMS, as we just discussed. Why is it important to find out these factors? Because identifying and treating these factors usually relieves the patient of pain, and that is what is most important. So, here we have a patient showing the clinical features of burning mouth syndrome. Patients usually describe the pain as burning, tingling, itching, pricking, or numbness. The primary location is the tongue, usually the anterior two-thirds. Other regions like anterior hard palate, mucosal aspect of the lip, and mandibular alveolar regions can also be affected, but the buccal mucosa and floor of the mouth are rarely involved. Usually more than one side is involved, and this is almost always bilateral and symmetric. In trigeminal neuralgia, we know that the pain is in the area of distribution of the nerve. Here in burning mouth syndrome, the pain does not follow the anatomic distribution of a peripheral sensory nerve. So that's one important point that you should remember. Most patients don't have any triggering factors, but the pain typically worsens when there are psychological stressors and improves with eating and drinking. Some patients might be able to recall and link the pain to a traumatic event, illness, dental procedure, or stress. For some patients, the burning sensation is aggravated by consuming hot foods or drink and relieved by cold. So you can see the patient can have many different complaints. Patients also complain of dry mouth or xerostomia because the basal salivary flow in BMS patients is usually significantly impaired. More than two-thirds of the patients complain of altered taste sensation, that is dysgeusia, along with the burning sensation. Patients experience a range of taste disturbances including persistent metallic or bitter taste and alterations in salty and sweet taste. Let's talk about the treatment options. There are no standard treatment protocols, but for successful management, we have to consider both physiologic and psychological aspects of the disease. The treatment includes topical medications, systemic medications, and behavioral therapy. The most established topical therapy is clonazepam 1 mg tablet, which should be sucked and subsequently spat out 3 times daily. Clonazepam is a benzodiazepine that acts as an agonist of the GABA receptor. The problem is that people may develop dependence because symptoms can return when medication is not continued. Common side effects are xerostomia, lethargy, and fatigue. The next topical therapy is capsaicin. It is a neuropeptide extracted from chili peppers that binds to TRPV1 receptor. We talked about this receptor, right? This receptor has the job of transmitting heat sensation. Long-term application of capsaicin reduces the number of TRPV1 receptors. This leads to desensitization of this pain receptor. Capsaicin is available as a rinse or oral gel applied to the dorsal aspect of the tongue 3 times daily for 14 days. Initially, the patients report an increase in burning sensation, but after a period of time, there is relief of pain. Another topical treatment option is laser. Low level laser therapy is reported to improve peripheral circulation. When circulation is improved, what happens? The cells get more oxygen, and it also helps remove noxious products. The laser treatment blocks C fiber depolarization. C fibers are the ones that respond to thermal, mechanical, and chemical stimuli and produce the sensation of dull, diffuse, burning, and delayed pain. So, blocking these fibers is how this laser therapy works. Now, let's talk about systemic medications. This includes clonazepam, 0.25 to 2 milligrams daily. Some studies show that it is not effective in improving mood, xerostomia, and taste dysfunction, but works best when normal salivary flow is present. Alpha lipoic acid is a coenzyme found in mitochondria, so our own body can produce it, but the quantity is not enough for treating a disease like BMS. That's why it's available as a dietary supplement in 200 to 600 milligram doses. It's shown to have neuroprotective and antioxidant properties, and that is thought to exert the neuroregenerative actions. Gabapentin is an anticonvulsant commonly used for neuropathic pain, and like clonazepam, it is a GABA agonist. Gabapentin in combination with alpha lipoic acid has shown a 70% success rate in the reduction of burning sensation. So this is a good treatment option. Lastly, we have to address the psychological component also, right? So cognitive behavioral therapy is recommended. In a study, it was found that those who received additional cognitive therapy for 12 to 15 sessions had decreased symptoms compared with a placebo group after 6 months. This proves that burning mouth syndrome has a psychological component. So, the overall management must consider this component as well.